success is doing little things consistently. It's not this big operation where you're suddenly, super successful. It's showing up every day, doing the little things. And that's whether you're talking about fitness or your business career or being a parent.
Hey, what's up, guys? Spencer Smith here, host of the Self-Funded with Spencer podcast, sponsored by Pareto Health, ClaimDoc, and PlanSight. Enjoy today's episode. All right, so why don't we get started? I'm here with Nick Glimcher. Did I say that correctly? All right, you're the founder of Blue Jeans, but jeans not like jeans we wear, jeans like our genetic code, correct?
Absolutely.
Awesome, man. Well, thank you for coming down. I really appreciate that. Shout out to Brandon for getting this hooked up. Today, we're going to cover the subject of pharmacogenetics / genomics, which you said is semantics, right? It doesn't really matter which one I use.
I use genetics, but tomato.
Tomato, which I think is really cool because I've had people bring this subject up in the past. However, we've never explored it deeply on a single episode, and so I'm really geeked out about getting the chance to do that. But Nick, before we go into all the technical stuff, let's get to know you real quick. I want to hear about who you are, your background, your entrepreneur journey, all that stuff. So why don't you take me back a little bit?
Yeah, so I'm from Columbus, Ohio. Huge Ohio State Buckeye fan. My family was in the commercial real estate business.
Okay.
And so via nepotism, I thought that's what I was supposed to do. My grandfather was a real estate developer. My dad was a real estate developer. My uncles are real estate developers. And so they went public in January of '94, and I was too young, so I'd missed that window. And you make your money going public, not really working for the machine. So I became a merchant developer in Arizona in the late '90s. And not because I was incredibly smart, but because the cap rate market was driving downward, we were, almost instantly successful.
Okay. Well, merchant developer, tell me what the difference is. I don't think I know
Basically, we didn't have the equity to refinance the project, so we would just sell them right away.
I see.
We'd build and sell them. And then fast forward to about '09 when the market crashed, I got taught some very valuable lessons, the most important being humility. And I like to tell people not out of innovation, but out of desperation, I created a business called Blue Square.
Okay.
And Blue Square was a credit card processing business that was originally designed as a way to navigate who needed rent reductions from the real estate business, because rent reductions were like mortgage modifications. Everyone wanted them. And so depending on what side of the mirror you were looking on, we began a divestiture of our non-performing real estate assets, and the Blue Square, the credit card business, grew significantly.
Okay.
We migrated in that credit card space to primarily an acquisition in private lending arm, and then we sold to a Goldman Sachs funded company in 2014.
Okay.
And at that point, I said to my boss, the fund manager at the time, I'm like, hey, we're going to do this all again, right? And he says, dinner's on me tonight, Nick, but we're out.
Yeah.
And I said, well, what do I do now? And he goes, well, we're getting in healthcare. And I said, I don't know anything about healthcare. He goes, what'd you know about credit cards 5 years ago? I said,
fair enough, yeah.
Fair point. And so we
do you know what his interest in going from the credit card processing to healthcare, why he's like, that's the path we need to go down?
No, they had diverse interests. I think that they felt like there was a lot of opportunity on the small, medium, private healthcare businesses.
Fair enough, yeah.
And that's really where we've focused. We have several companies that we've acquired, and we now run and manage those assets. We're typically not passive investors.
Okay, right on. And now, before we move on too far, I do want to actually talk about, because you were kind of a very high-level power lifter, and I think some of the fitness stuff will shape, I think, the direction we go with this. But would you tell me real quick kind of your powerlifting story? I think that's pretty cool.
Oh, I don't think it's super
interesting.
No, it's not super interesting. No, I competed in the late 90s, was national champion at one point, American record holder in the squat.
Can I ask what that was?
Oh gosh,
do you remember the number?
It was 505.
Was this
but I was
assisted
17.
or unassisted with a suit or raw or what?
It was assisted.
Okay.
So you were wearing gear.
505 at 17. My goodness, man.
But look, in today's world, that's nothing.
Yeah.
But back then it was something, and you know what it did is I'm a huge believer in discipline.
Yeah.
Okay, discipline outweighs motivation every day, and that's what I try to teach my kids through sports. is discipline.
Well, I'm with you there too, man. And I don't want to take us too far down that path because I know we got something to cover. But discipline, man, it's something I'm 40 now. I've discovered as I continue to evolve, like in health and healthcare and all that stuff. Discipline is like the one variable I can definitely control, and it's also the variable that seems to have the most bang for your buck in terms of ROI. And so it's just like I wish I had the same discipline at 17 that I have now, even though I felt I was pretty disciplined then. But I imagine the amount of discipline you got to have as a 17-year-old to set a squat record like that. I mean, you had to have been just laser focused, right? Does that come from family, parents? Like,
I think I just have this obsessive compulsive nature to myself. Sometimes it's healthy, sometimes it's unhealthy.
Yeah.
But again, you know, success is doing little things consistently. Mm-hmm. It's not this big operation where you're suddenly, you know, super successful. It's showing up every day, doing the little things. And that's whether you're talking about fitness or your business career or being a parent.
Yeah, absolutely, man. It's that idea, like once you finally zoom out and look at the progress you've made over a longer horizon, you can point to it and actually see it.
100%.
On a daily basis, you don't feel it. So it's just the commitment to the process, right? To
100%.
Get better every single day, even though it's not tangible quite in that shorter period of time. But anyway, so I want to go back, man. I just want to touch on that because it does shape who you are as a person. I think it's important I love just hearing people's stories because I've gotten a chance to hear so many cool things that people have done just in their early stages of their life that give me insight into who they are as a person. And so back kind of the idea of now you're getting into healthcare in 2014. What did that look like? What were you guys tackling at that point? Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments.
If looking back at it, the biggest thing is we didn't know what we didn't know. You know, our first foray is we bought a company we still own today called Prime Body.
Okay.
It's a hormone replacement company. And as I told you earlier, I'm not only the president, but a member. So I'm a huge believer in hormone replacement therapy. But as we grew, we wanted to get into the insurance side of business. And this was the toughest learning lesson that we had, which is dealing with insurance companies, dealing with them not wanting to pay for your goods or your services, and then trying to navigate that with doctor's orders. And some of those lessons were difficult.
Well, I've got a friend in the ABA therapy space right now, and he's navigating that exact thing, just getting through contracting and, you know, looking at, I've got a signed contract and they can't find it in their own system. He's like, I signed it 6 months ago and you still won't pay me, you know, things like that. Just the headaches that you don't think about when you're starting to stand up a company. Do you have a story or something you point to of like a really powerful lesson learned or a big lesson learned that you can think of?
Well, you know, we bought our first lab in 2015, and it was a partnership.
Okay.
And it was bought originally to be a blood lab to service our hormone patients.
Okay.
That failed miserably. Okay. We didn't understand how sensitive blood was to shipping. The patients would get these boxes in the house, and they'd have to figure out phlebotomy. If it could have gone wrong, it did.
It did, yeah.
And so we were prepared to either sell the asset at a loss or put in a chapter proceedings. And one day I got a call from the lab manager, and he says, and he's trying to save his job, and he says to me, he goes, Nick, can we run some toxicology specimens? And true story, I turn around, I'm like, what's toxicology? And he goes, well, it's drug testing. And I'm like, you know what, Ryan, do whatever you want.
Yeah.
And so he started running toxicology tests, and it started paying and reimbursing super well, and it kept us in the space.
Okay.
And that's really sort of evolved in who we become today. You know, and toxicology, generally speaking, has become a mainly esoteric test, but we've really evolved into antimicrobial stewardship, pharmacogenetics, precision medicine, And it really spurned from that one phone call. Otherwise, I don't think we'd be here today.
That's crazy, right? It's amazing how you can look back and go, I think that one little thing saved our business and turned it into what it is today. So as we enter, you sort of evolve this lab-based business. When does this idea of pharmacogenomics or genetics come into the fold?
Well, we were aware of pharmacogenetics, in 2016, 2017. We were doing it in sort of a reference format where other labs were running the test in a very small scale.
Okay.
And, when COVID happened, or actually right before COVID, we decided we were going to make a change, and toxicology was getting very, very difficult with the payers. They didn't want to pay for it. So the first thing that we did in our pursuit to deal with the problem of antimicrobial stewardship or proper prescribing around antibiotics was we built a new type of toxicology test. And there's still only one other lab in the United States that does this test. It's the same science as toxicology, but we're not focused on drugs of abuse or street drugs. We're looking at everyday maintenance medications, Plavix, Xarelto, Dininsoprol, even over the counters like Tylenol, naproxen, and aspirin. So these are maintenance medications that your chronic care patient, your Medicare patient's taking, and a pharmacy report's only going to tell you that the prescription was picked up, not that the prescription was ingested. And that leads us to a behavioral versus biological question. So if the drug isn't in their urine, did they not take it? Do they not want to take it? Or did they take it and the drug is not effective? And so that led us to pharmacogenetics. But, as we'll talk about in more detail, the problem with pharmacogenetics is that it doesn't fit in the current clinical workflow.
Okay.
And what Blue Genes is set out to do is to make sure that the information is applicable.
Okay. Well, so before we move on, because I think you've had it defined before. However, some people probably listening to this know what pharmacogenomics is. Some people probably don't. So in the interest of making sure everybody gets to come along, can you at least define what we mean when we say that big old word?
Yeah, from a layperson's perspective, it's really the science of what drugs work for you and what drugs don't. This is a foray into precision medicine. People like to use precision medicine and value-based care as buzzwords. Well, this truly is precision. Okay. Does this drug work for Spencer as an individual or does it not?
Yep.
And the science isn't new. The science has been around and commercially viable since 2010. And there's a reason why it hasn't had more widespread usage, and there's an applicability issue.
Okay. Well, so what we're testing is this is a swab test, correct? Right? So
it's a cheek
swab. Okay, so getting our saliva, probably dropping it at some canister, right, and then it gets shipped off for running this particular test, right? So, talk to me about that step. I know that's probably a little bit.
Well, I mean, it's
basic,
a buccal swab of the cheek.
Okay.
We're putting it in basically a little baggie. So, and it has stability that lasts up to 30 days in the Arizona sun, so we don't have we don't have a shipping concern as it relates to it. And I think from a timing perspective, what we learned during the pandemic is that people had the ability and capability to swab themselves and understand that process. So the pandemic has really pushed forward this initiative in many ways.
Okay. And so once that goes to the testing facility, right, it gets run, and then it's going to return sort of like what that person's genetic code looks like, and then it also is going to ping against drugs, right? Or tell me the process.
It's not whole genome sequencing. We're looking at known response genes, which impact your ability to respond to a medication, and CYP isozymes, which impact your ability to metabolize the medication appropriately. So what you would get is a 15 to 30 page report. I think ours happens to be 17 pages. But our position is that that's largely ineffective.
Okay.
The providers likely don't understand it, don't know how to read it, but more importantly, they don't even know it exists. And if they don't know it exists, they can't use the information to help the patient.
Okay. Yeah, and so the goal with this, right, before we get onto, I want to get into the specific application of Blue Genes, because that's where that automation, that's really excites me, what you guys are doing. But so if I'm an individual that has been swabbed, I've got this response, my doctor maybe has it in the old world, he's got the 17-page report, right? It's going to tell him or her what drugs might have contraindications for me, what might be useless, what might be dangerous, right? It's really taking that profile, pinging it against my gene sequencing, or what did you say it was called, or what would you?
Well, it's not whole genome
Not
sequencing.
whole genome. Okay, so then it's going to tell me, oh, well, this drug you're taking maybe is useless, right? Or this drug you're spending money on is probably not as effective as it should be, right?
I mean, that's generally speaking.
Okay.
You know what you're going to see. I mean, there's a lot more detail. There's genotypes and there's phenotypes. Also, there's additionally there's problems with paper tests. My company included that there's a limitation on how many drugs that we profile in these paper tests. So if the drug that you're interested in isn't profiled, the doctor's not going to know what to change. So
how come those have limitations in profiling?
Because that's just, you can't put every drug out there on a paper test. It would be 100 pages. And, that's one of the reasons why our software is effective, because it is the entire U.S. pharmacopoeia. You can query anything. Now, that doesn't mean that every drug that's available in the United States has a pharmacogenetic implication. They don't.
Okay.
About 80% of the drugs that are on the market have a pharmacogenetic implication.
So the other 20% just don't. You just can't tell, or
well, they're either not metabolized through the liver, and so therefore we're not going to be able to measure how you respond to it or how you metabolize it. Now, that doesn't mean ultimately that maybe there isn't some impact. That means we just don't know.
I see. Okay, so there's an unknown factor as well. Okay, so then as we start thinking about the application here, I think one of the things that you suggested, right, the reason why this hasn't sort of proliferated across the country and hit critical mass is because the limitations of, yes, I've got this report. Cool. Maybe my doctor doesn't know how to use it. Maybe he or she doesn't have time to use it, right? And so, yes, the information was great. It's just how do we actually put it into motion to be effective has been the constraint. Did I have that correct?
Yeah,
okay.
100%.
Okay. So then how are we solving for it? So now let's get into blue genes specifically. How are we solving for that?
Yeah. So we are a lab and we do run the test. But the test is a commodity. And I don't care what any of my competitors say. The average doctor couldn't tell you the difference between my test, Mayo Clinic's, or the Cleveland Clinic's test, or GeneSight, or whomever. So if we start from the premise that the test is a commodity, if your firm, if your self-insured employer or whomever was interested in pharmacogenetics, they would put out an RFP, and the low-cost bidder would likely win the story. The problem is, who's going to get the information? How are they going to get the information, and how are they going to apply it? Because the test itself, it's not like COVID. It's once in a lifetime. So the information isn't relevant. So it lends itself to obsolescence. Your genes are the same in 2023 as they are in 2043. And I don't care what anyone says, there is no doctor in the United States that's looking at pharmacogenetic data to make clinical prescribing decisions 5, 10, and 15 years after the test was resulted. And when you consider that the test was likely ordered by an unaffiliated provider group, the odds that someone even knows it exists are further diminished.
Sure.
So again, it's like we talked about, if the information isn't used, it is worthless.
Yep. So
what we had to do is we had to figure out the way to route this information through the system to make it applicable. So what Blue Genes is we're a clinical management tool. Okay. And the first thing we do is we simplify the information. As we discussed earlier, most doctors don't know how to interpret these reports properly. And I don't care how easy my competitors make it seem with these red, yellow, and green drug selection options. It's just not that simple. But more important than simplification is how we route the information through the system that makes it actionable. So we integrate with PBMs. We could integrate with an EMR, but there's limitations to that. So when we integrate with a PBM, when a script is sent in electronically, we capture data like pharmacy, prescription, payer, provider, patient, all of that information. Our intelligence then queries that data, and we send instantaneous notification back saying, do not adjudicate this script. It's not genetically efficacious.
And that's at the point of sale at the pharmacy itself.
Well,
correct?
it's hopefully
or before that.
Hopefully it's before. It's a negative outcome to have the member go to the pharmacy and be rejected.
Yep.
So what happens is a push notification goes to patient, and that can be via email or text message unless they've opted out, saying, hey, there's been a change to your prescription, much the same way that Walgreens would ping you today, say your prescription's not ready. So there's been a change to your prescription, please stand by. notification goes to provider saying the script doesn't work. Please choose from the following drugs that do work. And I call this the TikTok effect. Society has changed from the standpoint of how we can accept information and how we can react to information. So if we want information applied, we have to spoon feed it in 30 and 60-second increments, and we have to have a clear path of resolution. Mm-hmm. And that's what Blue Jeans does. It says for Spencer and this specific drug set, this is what you do and this is how you do it, and we make it very, very simple, and it can be done in seconds. Otherwise, it just won't get done. Mm-hmm. And so the beauty of it is that Blue Jeans becomes a fail-safe in the system that protects against catastrophic human error, and also allows us to protect the patient no matter where they seek care. So whether they're here in Dallas and they're going to their primary care, or they're on vacation and they slip and fall and they end up in the emergency room. So if we integrate with an EMR, we're only protecting the patient at that one location.
Okay, gotcha.
And that doesn't work. Life doesn't work that way.
Well, so what happens in that event? So let's say drug gets flagged, shouldn't take this. Here's a list of alternatives. Then it goes back to prescribing physician at that point, says, all right, of this list of medications. So you're not making the recommendation of which one to choose necessarily, correct? You're just offering alternatives?
Yeah, so okay. we give them all the alternatives. Typically, it is going to be based on our client, which is the payer plan or self-insured plan, their formulary.
Okay.
And we are going to send drugs that are not only genetically ethical for patient, but also cost-effective for plan. Altruistically, we want to see changes to prescribing, but we can't put our head in the sand. You have to understand that cost savings is a really important part of what we're doing out there if we want wide-scale adoption.
Well, and you're not necessarily eliminating pharmacy spend, right? The goal is not to say, don't take any drugs at all. It's take the most effective drugs or the safest drugs for that individual.
Yeah,
right?
We don't advocate drug-assisted treatment or not drug-assisted treatment.
Right.
We're just saying, don't be an experiment.
Yeah. Okay. And then so that I want to kind of close the loop there. That physician gets that list. Oh, okay, that alternative, actually, that one's appropriate. Then it goes back to how's it ping the system after that to close the loop?
Well, it's same way it starts. Okay. So he prescribes the new drug. The new drug will come back in a green lighted status, but it still goes through the same process where we accept the data.
Probably still double check it, right?
Yeah, we double check it, it's green lighted, and then a message is sent to patient saying your prescription is ready, patient goes to Walgreens. Now, there are instances where a prescription is done in a paper format where we will have a negative patient outcome, which is they are turned away at pharmacy. But quite frankly, it's better than being dead.
It's an inconvenience, right? It's versus perhaps something that's potentially either deadly or just, in the least worst case scenario, just useless that you're taking that particular
100%.
Yeah, okay. So then that goes back, gets prescribed. That loop that we just described, roughly speaking, how long is all that taking to transpire?
Well, from a Blue Jeans perspective, it's always seconds. Okay. But what we can't control is the time that it takes the provider to respond to the message.
Sure.
We cannot choose the drug for patient. We are simply a clinical management tool.
Okay. So then hopefully the whole primary goal is the member, the individual, the human being itself has been, the proper checks and balances have been put in place. So they are taking medication that's at least safe, but hopefully is most effective for 100%. Their condition. And that seems like an outcome that anybody would be, supportive of, that's in this equation. You would think.
You would think.
You would think.
Yeah.
Okay. But let's talk a little bit more logistics of this, right? This is a one-time test.
Yep.
What's the rough cost in today's, it's mid-2023, what's a rough cost of one of these tests?
Well, the Medicare LCD guidelines for this test, exceed $1,200 in some instances.
Oh, wow, okay.
We capitate with most plans at $299.
Okay.
And again, it's a one-time investment. The software is a PM fee, or a per member per month fee of $6.99. So the total spend for a member is $384 in year one. Now, if you retain that member in years 2 and beyond, you never pay the $299 again, so your only expense is the $699 a month. Now, to kind of give you perspective, we did 3 insurance actuarial studies for one of the big 5 insurance companies that we're starting a pilot with. One on SSRIs, one on opiates, and one on Plavix. I'll just talk about Plavix for a
Okay.
minute. We took publicly available Medicare data and we extrapolated it against all categories of service, and we were able to show this payer a $4,499 per member per year savings on just Plavix.
On just Plavix, okay.
Not the U.S. Pharmacopoeia, but Plavix.
Okay.
Now, the interesting notation on Plavix, and I think your viewers or listeners may be interested in it, is that generally speaking, none of the savings came from inappropriate drug dispensement costs, because Plavix is a cheap generic drug with favorable rebate. So the drug itself is cheap. It's a maintenance medication. What happens is that roughly 30% of the U.S. population, irregardless of sex or ethnicity, is what's considered to be an ultra-rapid metabolizer of Plavix. Essentially, it's a prodrug, goes through your system, your blood gets too thin. If you are ultra-rapid and you take Plavix, you are 8.5 times more likely to have a bleed event that could lead to stroke or hospitalization. 8.5 times. If you were stinted and you were given Plavix, the doctor can't tell you because my eyes are blue or my ears are big that Plavix won't work for me. He's not the amazing Kreskin. And the best case scenario, or likely best case scenario for me, is to be re-stinted in 7 to 10 days. Well, that's a $20,000 to $40,000 event. Maybe even more if you go to Memorial Hermann. Joking aside, but these are avoidable clinical outcomes.
Right.
And avoidable hospitalizations. And that's what we're really looking at, is not only how do we impact pharmacy spend, because we're not going to be experiments, but how do we impact avoidable clinical outcomes?
Yeah, I mean, there's a two-pronged impact here, right? One is the member themselves, right? There's a paternalistic, I'm providing a great benefit to my employees, this is a quality of life thing, and maybe even could save your life potentially, right? The other side of this is there a tangible return on my investment as an employer so that this becomes a no-brainer, right? Can I quantify if I were to do this, projecting outwardly, even though there's an expense maybe up front and an ongoing sort of maintenance expense, it'll be more than overcome by the savings, the potential savings in the future. And I think once you're able to prove both heads of that hydra, if you will, now you have a really efficacious solution for the marketplace. So it sounds like you're already looking and exploring that. And I'm sure when you have conversations with employers or consultants, you're already proving that out, right?
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Yeah, to your point, the first thing to understand is, look, I'm an evangelist for pharmacogenetics. I think everyone should have it. Unfortunately, that's not financially viable. Mm-hmm. So when we go to a self-insured plan or a government plan or whomever, we're not saying everyone should be tested. Okay.
That's right.
Sorry about that. We're not saying everyone should be tested. We're saying that your high-risk, high-utilizing members.
Yep.
Who are the people that are causing you money, or costing you money, rather? So we're going to focus on that membership. And then if we can get to a point where we're getting 3,000, 4,000, maybe even 5,000 members as part of a pilot project, and this is an aggregate, this isn't any one company, this is maybe get 12, 15 companies all doing, a couple hundred members.
Yep.
Then we perform a retrospective study, and that's at our expense. And what the retrospective study does is it takes the genetic data and we compare it to the previous 3 years of both pharmacy and medical data, and very simply put, if a patient was inappropriately prescribed in 2020, here was the clinical outcome associated with inappropriate prescription, here was cost of clinical outcome, here was cost of drug for duration taken, and we compare that to cost of our service and cost of the test, and hopefully that delta is large enough for us to earn a much larger population.
Sure. But so I think that was an important distinction to make. Is this is not just you go into a company with 500 lives and test all 500 people. You test the high utilizer cohort of the population. So roughly speaking, what are you seeing? What percentage of a population is that high utilizer?
I mean, it depends on the demographic, obviously, but on average, it's going to be about 10 to 20% of the population. If you're dealing with a skilled labor, maybe it's a little higher versus an in-office group.
Okay. And then now I want to get into the drugs themselves, right? You mentioned Plavix, which I think is a really good use case. But let's say I'm an employer or I'm a consultant listening to this, and I want to look at an employer, but I really want to kind of have some tangibility of like what type of drugs. Are we talking a lot of specialty drugs? Are we talking brand drugs? Are we talking even generics? Like, what is the use case for this, and what are some of the things that you can point to? These things are the ones that we look for as low-hanging fruit.
Well, the way I look at it and the way I describe it to people is focusing on drug category.
Okay.
We have a lot of impact in the mental health space. We talk about SSRIs and this type of treatment. That, in my mind, is pretty much a guessing game.
Okay.
And we're able to say day one, Prozac won't work for you. So why try it?
Why try it? Yeah.
Cardiac medication and cardiology impacts are huge. Beta blockers, anticoagulation drugs like Plavix have a lot of known data. Opiates and opiate prescribing, which obviously with the fentanyl epidemic is on everyone's mind, both politically and otherwise. So that's another area where we would have major impact. Diabetic medications. The only medications we really don't have a lot of benefit to are some of these newer monoclonal antibody medications.
How come? Why is that not?
Well, some of them aren't metabolized through the liver, but
so
I'm
you
not a
mentioned that
scientist.
before. But metabolization through the liver seems to be a constant that is required for this to work, correct?
It's not that it's a hard requirement, and again, I'm not a scientist. I'm an entrepreneur, but there's less data out there on it, and so we can't unequivocally say there's an impact here or not.
Okay. And then if I'm also, let's see, you mentioned kind of some of the, but conditionally speaking, if I have a large diabetic population, there's probably a good chance that this will make an impact. And what are some other chronic conditions?
Diabetes, cardiac disease, obesity, substance abuse, cancer, the things that you would think of that are like costing these plans a lot of money. And that's where you got to look at it. We're a niche product that is going to impact your spend in a problematic area.
Yeah, absolutely. So how do we move this from a niche product to become commonplace, right? Because it sounds, again, when I hear you describe the application for it, it makes sense, right? I understand there's a small, not small, but a financial hurdle that could potentially need to be overcome, even if it's just a psychological hurdle. But how do we turn this in, or how does this become the norm, if you will? You got to open up your crystal ball for me on this.
Yeah, one, right? I know. I think, our approach, and I think it bears noting, we believe we're going to be standard in care within 5 years.
Okay.
Our belief, and this isn't to sound arrogant or anything, is you're either coming to our party now or you're coming to our party late.
Yeah.
And fashionably late is cool. Really late is probably not as cool. What we're doing is we're focusing on large payer plan pilots, several state Medicaid pilots, including state of Louisiana is one that the governor there has signed off on a pilot.
Okay.
Federal agency pilots, and self-insured pilots. And we're working on a pilot right now with Hub International, with some of the companies that they represent. What our goal is between now and the end of 24 is to deliver enough data and enough evidence that when we go to a self-insured group or when we go to one of the large payer plans or state agency, it's no longer a question of is this going to work? Because we're going to say, hey, here's 50,000 members. Here's how they performed. Here's what would have happened had you had us in place. And not only are we saving money, but we're improving care. And we're specifically also improving care for underserved populations like Medicaid populations that are typically aren't getting the same level of care.
Well, and because this is all automated, once the test is done, right, that's the only sort of manual component of this, right, is getting the test physically returned and then run. The rest is automated, right? So there's not a scalability issue with that. Whether it's 50,000 lives or 500 lives, you flip on the switch and it's ready to go. So have you having to like sort of beef up the infrastructure, the tech infrastructure, in the event that millions of people might be coming on the next few years? Or
the biggest learning curve from us from the tech standpoint, I do not have a tech background, has been data security.
Okay. Yeah.
And that's been a huge topic for us politically and otherwise. Mm-hmm. And it's just a huge topic for the world in general, is how we protect the data. So that's been our toughest challenge. Scalability with this particular product isn't an issue. We grew significantly during COVID, so we've got more than enough labor to take on to take on major growth, but making sure that we were properly protecting people was a big hurdle for us to cross.
Well, yeah, it's important. I went through that in my last tech company as well, right? Data security was always top of mind.
Yep.
Many prospects, especially banking prospects that we dealt with, they just had so many rules around data security and integrity, which I totally get. As we zoom out, though, Nick, as we sort of go into the last sort of chapter, if you will, of this podcast, and talk big picture healthcare, I want to talk about the regulatory side of this, right, and the lobbying side of this, because it does seem that you guys have focused on that channel of sort of getting bipartisan support through legislature to prove the case, right? And so talk to me about deciding to go down that path and how it's sort of benefited the business itself.
Yeah, I'm not going to fib. I'm enjoying the political side of it. It's not without its challenges.
Sure.
And, part of the challenge is getting the time and the attention to really educate, because this is a complicated subject matter.
Yep.
But it's a really important subject matter. We live in a country where adverse drug reaction is the second leading cause of hospitalization, and every pharmacy, every EMR, and every PBM purports to have a drug-to-drug calculator or solution, yet it's not working. And so we realize that this is an issue, and the government realizes it's an issue. And so what are things that we can do in the near term that are, in the right perspective, relatively cost effective to make change? And I think pharmacogenetics is one of those things. And what you're seeing from a bipartisan perspective is you've got Senator Tim Scott and Senator Sherrod Brown co-sponsoring legislation right now in regards to coverage determinations for Medicaid patients. You've got, on the House side, you've got Eric Shawwell and Crenshaw from your home state that look to be like they're going to team up on pharmacogenetic legislation. And that's going to create more and more awareness for the product. So the fact that the government is proactively pushing this type of genetic information, I think, is incredibly critical. And we've been really forward in our education and getting involved, because there's a tremendous opportunity to benefit what is probably the largest population of patients, which are state and federal agency programming, and making sure they get the right care, because an ineffective drug is worthless.
Absolutely. And so why do you think, though, there's bipartisan support? Because it does seem to be there's not really a political side to this.
Yeah, because humanity and caring isn't a political issue.
Yeah.
It's being human. And I think, there is bipartisan support for healthcare reform. And unfortunately, and I can't give you the reason, healthcare is the last sector to ever adopt technology.
Oh my God.
And these fail-safes that we're creating with Blue Jeans, they exist in every other sector to protect against catastrophic failure. Yet healthcare, which keeps us alive and keeps us moving and keeps us in fitness or whatever you're into, is the last to adopt this. It doesn't make any sense.
Yep.
And, we continue to weigh down the provider with more and more requirements and pay him less and less. So the motivation for him to take on additional workload to take care of patient isn't there. So if we can do something that can make this easy for him to integrate, ethically, of course, he wants to do it.
Sure.
He wants to take care of the patient. And I think that, going back to the political headwinds, everyone wants to score a win for healthcare. And
it's what, 17-18% of our GDP right now, $4+ trillion. I mean,
yeah, and I think that we're seen, and thank God, but I think we're seen as a potential solution out there.
Yeah. Well, I love it, man. I mean, I do believe I agree literally with everything you just said, especially about our industry being so slow to adopt technology. I mean, you wonder, though, there's some headwinds that just based on the influence of money, right, in the pharmaceutical world, the manufacturers, that don't want constraints placed on the consumption of the drugs just for financial reasons. If I want to be a little bit conspiratorial, I think some of that's probably going on. But I think I'm glad. I mean, I think some of it started under Trump and has continued this exposure of the way that our pharmaceutical industry is constructed. There's a lot of light on it right now. And so this, again, is offering something that, based on that exposure, offers a solution for some of the bad practices or maybe just wasteful practices in general. Yeah. Are you feeling that a little bit?
Yeah, I look, I don't have anything bad to say about drug manufacturers or PBMs or otherwise.
Sure.
But what I do have to say is we want to be able to go to our provider and have confidence that what they're going to give us is going to work.
Mm-hmm, mm-hmm.
Okay? There's no need to take medication if it's ineffective. And I'm going to give you an anecdotal
Sure,
story.
Please.
Okay, so I'm self-insured, and we're not a huge company with 380 employees. And one of our employees, by the way, she gives me permission to tell her story. Before she worked for me in 2010, diagnosed with depression and anxiety, was hospitalized 6 times between 2010 and 2020 for anxiety. I'm going to turn this off.
Popular guy, man.
I know. For anxiety-related reasons. So in 2021, she's diagnosed with hypertension and given metoprolol as a beta blocker. Okay. Well, November 21, she has chest pain. By the way, she works out every day, 45 years old, relatively good shape. Has chest pain, goes to her primary care. Primary care tells her she's having a heart attack, sends her to the hospital. $17,000 later, she's discharged, no heart attack. So upon discharge, we do a pharmacogenetic test on her. What do we find out? She's been taking Prozac since 2010 with no clinical benefit and hospitalized 6 times in 10 years.
Jeez, okay, yeah.
Okay? The metoprolol was determined by the hospital system to be ineffective because she's not able to metabolize it. Mm-hmm. It caused the chest pain, which caused the hospitalization. So for $299, I could have saved myself $17,000.
Yeah.
And
you just save her all the literal heartache, no pun intended, but the literal heartache as well, right? Because it's not just the cost savings and the fact that it was a drug that didn't do anything. It actually was having negative impacts to her health simultaneously.
Yeah, and that story's anecdotal, but how often is it happening?
Sure.
And are we, there's all these programs and vendor programs to save money on insurance, and we sometimes will get lumped into that category. Mm-hmm. But a lot of these programs are stepping on dollars to pick up pennies. We're the opposite. This has such wide scale impact, and I hear from self-insured like, the pharmacy spend is 35% of plan cost or whatever it is, or 40% of plan cost. Yeah, we're gonna have major impact there. But what about the hospitalizations that are completely avoidable, that are monster expenses?
Yep.
And the great thing about what we're doing is we're not saying take our word for it. Come do a retrospective study with us. Let us show you unequivocally so you can take it to all of your employer clients and say, look what we were able to do here.
Yeah. I mean, there's things that start to enter into the realm of a no-brainer, right? And I don't say it's no-brainer because I don't want to spend other people's money, but there are things that start to enter into the lexicon of what I've been exposed to that just makes sense, right? And there's probably some other logistics and technical stuff that folks smarter than me would have questions about, but this makes sense to me, and so I could see why it sort of is on this cusp of perhaps expansion. I can see why you're having success at the state level. But let's talk about big picture of healthcare, Nick, because I think you have a good insight, especially with all the lobbying and the fact that you guys have been in front and working with regulators. I'm sure you have insight or line of sight into kind of where the healthcare ship is sailing, if you will. So not even just on the pharmacy side, but big picture stuff. So what are the things that you're prepping for in the next few years or that you expect to happen with our healthcare system?
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Well, I think we're coming out of a 3-year hiatus on healthcare.
Yeah.
So for 3 years, COVID was the only condition that existed. So what's happening right now is hospitals, payer plans, and everyone that's involved in healthcare has to learn how to be fiscally responsible again. And so we have to start looking at change and how we impact care. And how we impact care is deploying technology that's going to make healthcare with a scalpel detail as opposed to dropping a grenade.
Yep.
Right?
Yep.
And so that's what precision medicine is. It's scalpel surgery versus grenade care. And so, where we believe we're going is this precision medicine route. And we have to do things to mitigate our cost exposure. Otherwise, Medicare won't exist 20, 30 years from today. And so, one of the reasons I think we're having success in Washington is they need to find ways to cut money from these budgets. And this is in a time where, quite frankly, spending money in Washington is not very popular, especially on the Republican side. Okay, there's been a tremendous amount of legislation, the Build Back Better bill, and now law, and there's been a lot of fights over spending. So spending isn't popular. But when you talk about spending that's going to impact how we can care for people in the future, I think it's a really big deal.
Well, do you think economies of scale will continue to drive down the cost of the test itself? I mean, would it always have sort of a baseline cost associated with it? I
mean, I think that, we're going to continue to modify assays and bring reagent costs down to a point.
But there's a floor, right? It's
Yeah,
not going to go down to $5 maybe. Yeah.
No, but I mean, if you look at Pharmacogenetics in 2015, it was paying like $4,000 or $5,000 a test. Now it's, the Medicare guidelines are anywhere from, like, say, $800 to $1,200. We're at $299 at a capitation rate. So I think you'll see it come down a little bit, but I think it's pretty stabilized at where it is.
Well, and I didn't even think about this, but obviously this is portable. Let's say I get this I myself have the test at my previous employer. The data still exists, but my new employer might not deploy blue jeans, correct? But if they did, theoretically, that assay or the test is still...
Well, the test will follow you.
Yeah.
But again, our integration is at the PBM level.
Yeah.
So if you're no longer associated with that plan or that PBM, your information won't be routing through the system if your new employer has this situation.
Well, but
now you can use it,
Yeah.
like you can log on to your app and, like you do use any other app.
But then I guess theoretically then you make some very, very vocal proponents of this and say, hey, Mr. and Mrs. Employer, we need this at my new place too, right?
Well, it's always nice to have advocates.
Yes, yeah. So, all right, so closing thoughts, Nick, I appreciate we probably talked about an hour or so, and thanks for taking me through your journey personally, but really explaining the subject to me. But anything you want to leave the audience with before we part?
I think that the one thing that I would say is that as you're representing self-insured companies, we're talking about an inflationary environment, a raising interest rate environment. I'm a business owner myself. And this product does require investment. It requires investment, so you got to spend money to make money, or save money in this case. But as you look at your options of what you're presenting to your employers, this is easily deployable. It is information that's cutting edge. It is interesting to the employee population to have access to this. And altruistically, you're going to be part of the change of how prescribing is done. No longer are we going to be experiments. We're going to know because I, for one, don't want to be an experiment. I don't want my kids to be experiments.
Exactly. Yeah.
And so we just want to be considered as one of these important vendors when you look at cost savings programs.
Yeah, awesome, man. Well, I appreciate that, and I suspect we'll get a little attention. I don't have a humongous audience, but I have an audience that is passionate about this subject, and so my hope is that it'll get some attention on you guys. You guys obviously are doing really well, but anything we can sprinkle on that fire will be great.
Yeah, look, I really appreciate having you, Spencer. Obviously, this place is great.
It's pretty cool, right?
Yeah,
it's
really
worst case
cool.
scenario, you got to see a really cool studio and have a podcast conversation. Well, Nick, again, it's been a pleasure. Shout out to Brandon again for setting this up, and I look forward, maybe we'll do this a retrospective a couple years down the line.
I hope so.
Let's do it, man.
I hope so.